Question 1. A 58-year-old male with a history of hypertension and type 2 diabetes mellitus is admitted to the ICU with profound dehydration, serum glucose of 980 mg per deciliter, serum osmolality of 360 mosm/kg, and a pH of 7.38. There are no ketones in the urine. Which primary nursing intervention is most critical at this time? A. Administer regular insulin intravenously at 0.1 units/kg/hr. B. Prepare to administer a bolus of 10 units of regular insulin subcutaneously. C. Initiate intravenous 0.9% sodium chloride at 1 liter/hour. D. Monitor for signs of cerebral edema hourly. Answer: C. Initiate intravenous 0.9% sodium chloride at 1 liter/hour. This question tests your knowledge of hyperosmolar hyperglycemic state, HHS, a severe complication of diabetes characterized by extreme hyperglycemia, hyperosmolality, and dehydration without significant ketoacidosis. The key clues are the serum glucose of 980 mg per deciliter, serum osmolality of 360 mosm/kg, profound dehydration, and a pH of 7.38 with no ketones, clearly indicating HHS over DKA. The initial and most critical intervention for HHS is aggressive fluid resuscitation with isotonic saline, 0.9% sodium chloride, to correct severe dehydration and improve renal perfusion, as this directly addresses the hyperosmolar state. For example, a patient might receive 1 to 2 liters of NS in the first hour to rapidly restore intravascular volume. Remember, while insulin is necessary, fluid replacement is the immediate priority to stabilize hemodynamics and gradually lower glucose in HHS. Question 2. A patient with severe hyponatremia, serum sodium 115 milliequivalent/L, due to syndrome of inappropriate antidiuretic hormone, SIADH, is exhibiting mild confusion. Which medication should the nurse anticipate administering to help correct the sodium imbalance? A. Desmopressin, DAP. B. Furosemide, Lasix. C. Vasopressin. D. Conivaptan, Vaprisol. Answer: D. Conivaptan, Vaprisol. This question is designed to assess your understanding of pharmacological management for SIADH, a condition where excessive antidiuretic hormone causes water retention and dilutional hyponatremia. The keyword severe hyponatremia with mild confusion suggests the need for intervention beyond just fluid restriction, especially since the goal is to raise serum sodium safely. Conivaptan is a vasopressin receptor antagonist that blocks the effect of ADH in the renal tubules, promoting water excretion without significant sodium loss, thereby increasing serum sodium levels. For instance, it might be used when fluid restriction alone isn't sufficient or in more symptomatic cases, helping the body shed excess water. Remember, in SIADH, the primary issue is too much water, so a medication that helps the body excrete water is the appropriate choice. Question 3. A 45-year-old female presents to the emergency department with sudden onset headache, palpitations, diaphoresis, and severe hypertension, BP 220/110 mmHg. Her medical history is otherwise unremarkable. The nurse suspects a pheochromocytoma. What is the most important initial nursing intervention to prepare for? A. Administering a beta blocker intravenously. B. Initiating a continuous infusion of a calcium channel blocker. C. Preparing to administer an alpha-adrenergic blocking agent. D. Encouraging the patient to ambulate to lower blood pressure. Answer: C. Preparing to administer an alpha-adrenergic blocking agent. This question tests your critical thinking regarding the immediate management of a pheochromocytoma crisis, a rare but life-threatening condition caused by excessive catecholamine release. The key clues are the sudden onset headache, palpitations, diaphoresis, and severe hypertension, which are classic symptoms of this adrenal tumor. The most important initial intervention is to administer an alpha-adrenergic blocking agent, such as phentolamine or phenoxybenzamine, to block the vasoconstrictive effects of norepinephrine and prevent a hypertensive crisis or myocardial infarction. For example, giving a beta blocker first could worsen hypertension due to unopposed alpha-adrenergic stimulation. Always remember to A before B in pheochromocytoma, alpha blockade before beta blockade to safely control blood pressure. Question 4. A patient in diabetic ketoacidosis, DKA, has a blood glucose of 250 mg per deciliter, anion gap of 18, and pH of 7.28 after receiving insulin and fluids. Which change in the insulin infusion rate or type of intravenous fluid should the nurse anticipate next? A. Increase the regular insulin infusion rate. B. Change intravenous fluids to 0.45% sodium chloride. C. Add dextrose, D5W, to the intravenous fluids. D. Discontinue the insulin infusion immediately. Answer, C. Add dextrose, D5W, to the intravenous fluids. This question assesses your knowledge of the appropriate management of DKA as blood glucose levels decrease, specifically focusing on preventing hypoglycemia while continuing to clear ketones. The critical clues are the blood glucose 250 mg per deciliter, approaching resolution of hyperglycemia, and the anion gap of 18 with pH of 7.28, indicating persistent acidosis and ketones. Once the blood glucose approaches 200 to 250 mg/dl, dextrose, typically D5W, should be added to the intravenous fluids to prevent hypoglycemia while continuing the insulin infusion to allow for ongoing ketone body metabolism and resolution of the metabolic acidosis. For example, abruptly stopping insulin or changing to hypotonic saline without dextrose could lead to hypoglycemia or prolong the ketoacidosis. Always remember to add dextrose to 4 fluids when glucose hits 200 to 250 mg/dl in DKA to allow the insulin drip to continue until the anion gap closes. Question 5. A patient with a traumatic brain injury develops polyuria, urine output of 500 ml per hour, and a serum sodium of 158 milliequivalent/L. Urine-specific gravity is 1.002. Which medication should the nurse prepare to administer? A. Furosemide, Lasix. B. Desmopressin, DAP. C. Spironolactone, Aldactone. D. Hydrochlorothiazide. Answer, B. Desmopressin, DAP. This question evaluates your understanding of diabetes insipidus, DI, a condition characterized by inadequate production or response to antidiuretic hormone, leading to excessive water loss. The critical clues are polyuria, urine output of 500 ml per hour, serum sodium of 158 milliequivalent/L, hypernatremia, and urine-specific gravity of 1.002, very dilute urine. These findings are classic for DI. Desmopressin, DAP, is a synthetic analog of antidiuretic hormone and is the primary treatment for central DI, as it replaces the missing hormone and reduces urine output, thereby helping to correct hypernatremia. For example, a patient with DI might receive DAP intranasally or intravenously to decrease their excessive urine output. Remember, in DI, the body is losing too much water, so replacing the antidiuretic hormone is the key to re-establishing fluid balance. Question 6. A patient in critical care has been receiving high-dose corticosteroids for several weeks following a severe inflammatory condition. The physician orders a gradual taper of the corticosteroids. The nurse understands that abrupt cessation could precipitate which life-threatening endocrine emergency? A. Thyroid storm. B. Myxedema coma. C. Adrenal crisis. D. Hyperosmolar hyperglycemic state, HHS. Answer, C. Adrenal crisis. This question tests your knowledge of the risks associated with long-term corticosteroid therapy and the importance of a gradual taper. The keyword is high-dose corticosteroids for several weeks, indicating that the patient's adrenal glands have likely suppressed their natural cortisol production due to the exogenous steroids. Abrupt cessation of corticosteroids can lead to an adrenal crisis, a life-threatening condition characterized by severe hypotension, hypoglycemia, and electrolyte imbalances, because the body cannot produce enough cortisol to handle stress. For instance, the adrenal glands need time to wake up and resume natural hormone production, similar to how muscles atrophy without use and need to be reconditioned. Always remember to taper corticosteroids slowly to prevent a potentially fatal adrenal crisis. Question 7. A patient with known adrenal insufficiency presents with nausea, vomiting, abdominal pain, severe hypotension, BP 70/40 mmHg, and hypoglycemia. After initiating fluid resuscitation, which medication is the priority for the nurse to administer? A. Regular insulin intravenously. B. Dexamethasone intravenously. C. Hydrochlorothiazide orally. D. Furosemide intravenously. Answer, B. Dexamethasone intravenously. This question focuses on the immediate pharmacological management of an adrenal crisis, Addisonian crisis, a critical endocrine emergency. The crucial clues are known adrenal insufficiency, nausea, vomiting, abdominal pain, severe hypotension, and hypoglycemia, which are classic signs of insufficient cortisol and aldosterone. After initiating fluid resuscitation to address the hypovolemia, the priority is to administer a rapid-acting corticosteroid, such as intravenous dexamethasone or hydrocortisone, to replace the deficient hormones and reverse the crisis. For example, delaying corticosteroid administration can worsen shock and increase mortality. Always remember that steroids are the definitive treatment for adrenal crisis, and prompt administration is life-saving. Question 8. A patient is admitted with myxedema coma. The nurse should anticipate administering which initial critical intervention? A. Intravenous levothyroxine. B. Oral propylthiouracil, PTU. C. Intravenous fluid bolus with 0.9% sodium chloride. D. Oxygen supplementation via nasal cannula only. Answer. A. Intravenous levothyroxine. This question assesses your understanding of the emergency management of myxedema coma, a severe, life-threatening manifestation of hypothyroidism. The concept being tested is the immediate replacement of thyroid hormones. The key is recognizing myxedema coma as a profound hypothyroid state requiring urgent hormone replacement. Intravenous levothyroxine is the priority because it directly replaces the deficient thyroid hormone, which is essential to reversing the metabolic slowdown that characterizes this condition. For instance, oral medications are ineffective due to severely decreased gastrointestinal absorption and the urgency of the situation. Always remember that immediate thyroid hormone replacement is paramount in myxedema coma, often accompanied by supportive care like warming and ventilatory support. Question 9. A critical care patient develops acute hypercalcemia, serum calcium 14, 5 mg/dl, secondary to hyperparathyroidism. The patient is exhibiting lethargy and polyuria. What is the most appropriate initial nursing intervention? A. Administer oral calcium supplements. B. Restrict fluid intake to prevent fluid overload. C. Initiate intravenous 0.9% sodium chloride at a rapid rate. D. Prepare for immediate surgical parathyroidectomy. Answer: C. Initiate intravenous 0.9% sodium chloride at a rapid rate. This question tests your knowledge of the emergency management of severe hypercalcemia, often seen in conditions like hyperparathyroidism or malignancy. The critical clues are acute hypercalcemia, serum calcium 14, 5 mg/dl, lethargy, and polyuria, which indicate symptomatic hypercalcemia. The most appropriate initial intervention is aggressive intravenous hydration with 0.9% sodium chloride to restore extracellular fluid volume, increase renal calcium excretion, and dilute serum calcium. For example, rapid fluid administration can help wash out excess calcium through the kidneys. Remember that hydration is the cornerstone of initial hypercalcemia treatment, helping to protect the kidneys and reduce serum calcium levels. Question 10. A patient with type 1 diabetes mellitus presents to the ED with Kussmaul respirations, fruity breath, and a blood glucose of 550 mg per deciliter. Arterial blood gases show pH 7, 15, HCO3 8 milliequivalent/L, and PCO2 25 mm of mercury. The patient is alert and oriented. Which action should the nurse prioritize first? A. Administer a rapid 4 bolus of 0.45% sodium chloride. B. Administer 10 units of regular insulin subcutaneously. C. Establish for access and initiate a continuous infusion of 0.9% sodium chloride. D. Prepare to administer intravenous sodium bicarbonate. Answer: C. Establish for access and initiate a continuous infusion of 0.9% sodium chloride. This question assesses your immediate priorities in managing diabetic ketoacidosis, DKA, a life-threatening complication of diabetes. The key clues are Kussmaul respirations, fruity breath, blood glucose of 550 mg per deciliter, and the ABG values, pH 7, 15, HCO3 8, indicative of severe metabolic acidosis, all classic signs of DKA. The absolute priority is to establish intravenous access and initiate aggressive fluid resuscitation with isotonic saline, 0.9% sodium chloride, to correct dehydration and improve renal perfusion. For instance, while insulin is crucial, correcting hypovolemia and dehydration takes precedence to ensure tissue perfusion before insulin can effectively lower glucose and clear ketones. Always remember that in DKA, fluids come first to restore circulating volume and prepare the body for insulin therapy. Question 11. A critical care patient post-transsphenoidal hypophysectomy for a pituitary tumor develops significant polyuria with a urine output of 400 ml per hour for 3 consecutive hours. Serum sodium is 148 milliequivalent/L, and urine osmolality is 100 mosm/kg. The nurse should anticipate which intervention? A. Administer a rapid infusion of D5W. B. Restrict oral fluid intake to 1,000 ml per day. C. Administer vasopressin, pitressin, subcutaneously. D. Prepare for surgical re-exploration of the pituitary. Answer: C. Administer vasopressin, pitressin, subcutaneously. This question tests your ability to recognize and manage central diabetes insipidus, DI, in a specific high-risk population, post-pituitary surgery. The keyword clues are post-transsphenoidal hypophysectomy, polyuria with 400 milliliters per hour for 3 consecutive hours, serum sodium 148 milliequivalent/L, hypernatremia, and urine osmolality 100 mosm/kg, very dilute urine. These findings strongly indicate DI due to insufficient ADH production. Administering vasopressin, or a similar ADH analog like desmopressin, is the appropriate treatment to replace the missing hormone, reduce excessive urine output, and help normalize serum sodium. For example, giving 4 fluids without replacing ADH would just be chasing the fluid losses. Always remember that in DI, the core problem is lack of ADH, so replacing it is the direct and most effective solution. Question 12. A patient with a history of Graves' disease is admitted with tachycardia, HR 130 bpm, hyperthermia, temp 104 degrees Fahrenheit, altered mental status, and severe agitation. The nurse recognizes these symptoms as indicative of thyroid storm. Which medication is a priority to administer after initial stabilization and before definitive treatment? A. Levothyroxine. B. Propranolol. C. Potassium iodide. D. Amiodarone. Answer B. Propranolol. This question tests your critical care management of thyroid storm, a life-threatening hypermetabolic state. The key clues are tachycardia, HR 130 bpm, hyperthermia, temp 104 degrees Fahrenheit, altered mental status, and severe agitation, which are hallmark signs. After initial stabilization, e.g., airway, breathing, circulation, the priority before definitive thyroid-blocking agents or iodine is to control the peripheral effects of thyroid hormones. Propranolol, a non-selective beta blocker, rapidly decreases heart rate, reduces tremors, and can inhibit the peripheral conversion of T4 to T3, making it a critical initial therapy. For instance, while antithyroid drugs are essential, managing the immediate life-threatening symptoms with a beta blocker buys time. Remember, in thyroid storm, you want to block the effects of the thyroid hormones as quickly as possible, and beta blockers do just that. Question 13. A patient with a severe head injury is receiving intravenous fluids. Over the last 12 hours, the patient's urine output has been consistently low, 30 ml/Hr, serum sodium has dropped from 138 milliequivalent/L to 125 milliequivalent/L, and serum osmolality is 260 mosm/kg. Urine osmolality is 450 mosm/kg. What is the most likely cause of these findings? A. Diabetic ketoacidosis, DKA. B. Diabetes insipidus, DI. C. Syndrome of inappropriate antidiuretic hormone, SIADH. D. Adrenal crisis. Answer C. Syndrome of inappropriate antidiuretic hormone, SIADH. This question requires you to differentiate between endocrine fluid and electrolyte imbalances based on laboratory and clinical findings. The concept being tested is recognizing SIADH. The key clues are low urine output, 30 ml/Hr, a significant drop in serum sodium to 125 milliequivalent/L, hyponatremia, serum osmolality 260 mosm/kg, hypoosmolality, and urine osmolality 450 mosm/kg, inappropriately concentrated urine despite hyponatremia. These findings are classic for SIADH, where excessive ADH leads to water retention and dilutional hyponatremia. For example, if a patient were in DI, their urine output would be high and dilute, not low and concentrated. Always remember that SIADH is characterized by too much ADH, too much water, resulting in concentrated urine and dilute blood. Question 14. A patient is being treated for adrenal crisis. Which laboratory value would indicate a positive response to treatment with corticosteroids and fluids? A. Decreased serum glucose. B. Increased serum potassium. C. Normalization of blood pressure. D. Worsening metabolic acidosis. Answer: C. Normalization of blood pressure. This question tests your understanding of the effectiveness of treatment for adrenal crisis, focusing on a critical outcome parameter. The concept is evaluating the immediate impact of corticosteroid and fluid therapy. A key feature of adrenal crisis is severe hypotension due to hypovolemia, vasodilation, and decreased vascular tone resulting from cortisol deficiency. Therefore, normalization of blood pressure is a primary and immediate indicator that the treatment is effective in reversing the circulatory collapse. For instance, while other lab values will also improve, stable blood pressure demonstrates that the body is responding to the replacement of essential hormones and fluid. Remember that stabilizing hemodynamics is paramount in adrenal crisis, making blood pressure a crucial marker of improvement. Question 15. A patient with diabetic ketoacidosis, DKA, has a serum potassium level of 2 milliequivalent/L. The nurse anticipates an order to add potassium to the intravenous fluids, after which action? A. The blood glucose reaches 100 mg per deciliter. B. Urine output is established. C. Arterial pH normalizes. D. Insulin infusion has been initiated. Answer: B. Urine output is established. This question challenges your knowledge of electrolyte management in DKA, specifically the timing of potassium replacement. The concept is ensuring adequate renal function before administering potassium. Although patients with DKA often have a total body potassium deficit, their initial serum potassium can be normal or even elevated due to acidosis and fluid shifts. Administering potassium before urine output is established, indicating adequate renal function, risks hyperkalemia, as the kidneys are the primary route for potassium excretion. For example, once urine output is confirmed, potassium can be safely added to 4 fluids to prevent or treat hypokalemia as insulin drives potassium back into cells. Always ensure good urine output before giving potassium in DKA to prevent life-threatening hyperkalemia. Question 16. A patient is admitted to the ICU with suspected myxedema coma. Besides administering thyroid hormone, what is another critical nursing intervention to protect the patient from immediate complications? A. Frequent administration of dextrose 4 to prevent hyperglycemia. B. Aggressive fluid resuscitation to correct hypervolemia. C. Continuous cardiac monitoring for bradycardia and arrhythmias. D. Placing the patient in a hypothermic environment to reduce metabolic demand. Answer: C. Continuous cardiac monitoring for bradycardia and arrhythmias. This question tests your awareness of the cardiovascular complications associated with myxedema coma, a severe form of hypothyroidism. The critical clue is myxedema coma, which implies a profound slowing of metabolic processes affecting all body systems, including the heart. Patients in myxedema coma are highly susceptible to severe bradycardia, heart block, and other life-threatening arrhythmias due to the decreased cardiac contractility and electrical instability caused by low thyroid hormone levels. For example, while thyroid hormone replacement is primary, monitoring the heart continuously ensures early detection and intervention for these dangerous cardiac events. Remember that the heart is especially vulnerable in myxedema coma, making continuous cardiac monitoring a non-negotiable safety measure. Question 17. A patient with a history of type 2 diabetes is found unresponsive. Fingerstick glucose is 35 mg per deciliter. After administering glucagon intramuscularly, what is the next most important nursing action? A. Prepare for an insulin infusion. B. Monitor blood glucose every 4 to 6 hours. C. Recheck blood glucose in 15 minutes and provide a complex carbohydrate once awake. D. Administer intravenous 0.9% sodium chloride rapidly. Answer: C. Recheck blood glucose in 15 minutes and provide a complex carbohydrate once awake. This question focuses on the immediate post-treatment care for severe hypoglycemia in a critical care setting. The concept being tested is the transient nature of glucagon's effect and the need for sustained glucose. The keyword clues are unresponsive, glucose 35 mg per deciliter, and administering glucagon. While glucagon effectively raises blood glucose, its effect is often short-lived. Therefore, it's crucial to recheck blood glucose in 15 minutes to ensure recovery and prevent recurrence, and once the patient is able to swallow, provide a complex carbohydrate, like crackers or toast, followed by a protein source to provide sustained glucose and prevent another drop. For example, simply raising the sugar temporarily without follow-up can lead to a rapid return of hypoglycemia. Always remember that severe hypoglycemia requires both immediate treatment and follow-up to ensure stable glucose levels. Question 18. A patient is admitted with a suspected pheochromocytoma. While awaiting surgery, the patient suddenly develops severe chest pain, elevated cardiac enzymes, and ECG changes consistent with myocardial ischemia. The nurse understands these findings are most likely due to A. Hypoglycemia from excessive insulin release. B. Adrenal insufficiency from tumor necrosis. C. Extreme vasoconstriction and increased myocardial oxygen demand from catecholamine surge. D. Dilutional hyponatremia from aggressive fluid administration. Answer: C. Extreme vasoconstriction and increased myocardial oxygen demand from catecholamine surge. This question tests your understanding of the cardiovascular complications that can arise from a pheochromocytoma. The core concept is how excessive catecholamines impact the heart. The key clues are: suspected pheochromocytoma, suddenly develops severe chest pain, elevated cardiac enzymes, and ECG changes consistent with myocardial ischemia. These symptoms are a direct result of the massive release of norepinephrine and epinephrine from the tumor, leading to profound systemic and coronary vasoconstriction, increased heart rate and contractility, and a dramatic increase in myocardial oxygen demand, potentially causing a catecholamine cardiomyopathy or myocardial infarction. For instance, it's like the heart is constantly running a marathon without proper blood supply. Remember that pheochromocytoma can cause a direct and severe cardiac insult due to overwhelming catecholamine release. Question 19. A critical care patient with a history of Addison's disease, primary adrenal insufficiency, develops new-onset fever, severe weakness, and diffuse abdominal pain. The nurse notes a blood pressure of 85/50 mm of mercury and a heart rate of 115 bpm. Which initial laboratory result would the nurse expect to find? A. Hypernatremia and hyperkalemia. B. Hyponatremia and hyperkalemia. C. Hypernatremia and hypokalemia. D. Hyponatremia and hypokalemia. Answer: B. Hyponatremia and hyperkalemia. This question assesses your knowledge of the characteristic electrolyte imbalances seen in adrenal crisis, particularly with primary adrenal insufficiency. The clues are Addison's disease, fever, severe weakness, diffuse abdominal pain, BP 85/50 mm of mercury, and HR 115 bpm, all pointing to an acute adrenal crisis. In primary adrenal insufficiency, there is a deficiency of both cortisol and aldosterone. Aldosterone deficiency leads to impaired sodium reabsorption and potassium excretion in the kidneys. Therefore, you would expect hyponatremia, low sodium, due to sodium loss, and hyperkalemia, high potassium, due to potassium retention. For example, the body loses its ability to regulate these vital electrolytes without sufficient aldosterone. Always remember that Addison's disease causes salt wasting, hyponatremia, and potassium hoarding, hyperkalemia. Question 20. A patient in the ICU with severe sepsis and multi-organ dysfunction develops a serum glucose of 700 mg per deciliter without a history of diabetes. Arterial blood gases show pH 7, 32, HCO 320 milliequivalent/L, and a serum osmolality of 345 mosm/kg. The nurse understands this clinical picture is most consistent with A. Diabetic ketoacidosis, DKA. B. Hypoglycemia. C. Hyperosmolar hyperglycemic state, HHS. D. Adrenal crisis. Answer, C. Hyperosmolar hyperglycemic state, HHS. This question tests your ability to differentiate between severe hyperglycemic crises, particularly in a non-diabetic patient. The concept is recognizing the distinct features of HHS. The key clues are serum glucose of 700 mg per deciliter, no history of diabetes, pH 7, 32, HCO 320 milliequivalent/L, no significant acidosis, and serum osmolality of 345 mosm/kg, significant hyperosmolality. This constellation of findings is classic for HHS, which can be precipitated by severe illness like sepsis in individuals who may not have a prior diabetes diagnosis, presenting with profound hyperglycemia and dehydration but without the prominent ketoacidosis seen in DKA. For example, the patient's pancreas is still producing some insulin, preventing severe ketone formation. Always remember that HHS is characterized by extremely high glucose and osmolality, often in the setting of severe illness, with less acidosis than DKA. Question 21. A patient with central diabetes insipidus, DI, is receiving desmopressin. Which assessment finding indicates an overdose of desmopressin? A. Increased urine output. B. Hypernatremia. C. Signs of fluid overload and hyponatremia. D. Increased thirst. Answer, C. Signs of fluid overload and hyponatremia. This question focuses on recognizing a critical complication of desmopressin therapy for DI. The concept tested is the effect of too much antidiuretic hormone. Desmopressin replaces the missing ADH in DI. If too much desmopressin is administered, it causes excessive water reabsorption by the kidneys, leading to fluid overload, e.g., weight gain, edema, crackles, and hyponatremia, low serum sodium, due to dilutional effects, essentially mimicking SIADH. For example, a patient might experience headaches or confusion from brain swelling. Always remember that desmopressin's goal is to balance fluid, so an overdose will swing the patient from DI, too much water loss, to a state of too much water retention and low sodium. Question 22. A patient with a history of thyroid cancer, who underwent a total thyroidectomy, is now experiencing circumoral paresthesia and muscle twitching. Chvostek's sign is positive. Which immediate intervention should the nurse anticipate? A. Administer intravenous potassium chloride. B. Administer intravenous calcium gluconate. C. Administer oral magnesium supplements. D. Prepare for immediate reintubation. Answer B. Administer intravenous calcium gluconate. This question tests your ability to recognize and manage acute hypocalcemia, a potential complication following total thyroidectomy due to inadvertent removal or damage to the parathyroid glands. The key clues are post-total thyroidectomy, circummoral paresthesia, muscle twitching, and a positive Chvostek's sign, all classic symptoms of hypocalcemia. Intravenous calcium gluconate is the immediate intervention for symptomatic hypocalcemia to rapidly increase serum calcium levels and prevent life-threatening complications like laryngospasm or seizures. For example, oral calcium would be too slow, and magnesium is secondary unless specifically indicated. Always remember that sudden onset of paresthesias and muscle twitching after thyroid surgery means checking for hypocalcemia and being ready with 4-calcium. Question 23. A patient in thyroid storm is receiving propylthiouracil, PTU, and propranolol. The nurse understands that PTU works primarily by A. Blocking the peripheral conversion of T4 to T3. B. Inhibiting the release of preformed thyroid hormone. C. Decreasing the synthesis of new thyroid hormones. D. Directly destroying thyroid gland tissue. Answer C. Decreasing the synthesis of new thyroid hormones. This question assesses your pharmacological knowledge regarding the mechanism of action of propylthiouracil, PTU, in the context of thyroid storm. The concept is understanding how antithyroid medications function. PTU is an antithyroid drug that primarily works by decreasing the synthesis of new thyroid hormones, T3 and T4, within the thyroid gland. Additionally, PTU also has a secondary effect of blocking the peripheral conversion of T4 to the more active T3. For instance, this dual action makes it very effective in rapidly reducing circulating thyroid hormone levels during a crisis. Remember that PTU's main job is to stop the thyroid gland from making more of the problematic hormones. Question 24. A critical care nurse is managing a patient with diabetic ketoacidosis, DKA, who has improved. The current glucose is 220 mg per deciliter, pH is 7.34, and the anion gap is 12 milliequivalent/L. The patient is awake and able to tolerate oral intake. What is the most appropriate next step in transitioning care? A. Continue intravenous insulin and intravenous dextrose until discharge. B. Discontinue intravenous insulin and start long-acting insulin subcutaneously. C. Transition to subcutaneous insulin regimen, basal bolus, and discontinue intravenous insulin. D. Increase the intravenous insulin infusion rate to prevent rebound hyperglycemia. Answer C. Transition to subcutaneous insulin regimen, basal bolus, and discontinue intravenous insulin. This question focuses on the crucial transition phase of DKA management from intravenous to subcutaneous insulin. The concept is ensuring a smooth and safe transition to prevent recurrence of DKA. The key clues are that the patient has improved with glucose 220 mg per deciliter, pH 7.34, and anion gap 12 milliequivalent/L, indicating resolved acidosis, and the patient is awake and able to tolerate oral intake. Once DKA is largely resolved and the patient can eat, it's appropriate to transition to a subcutaneous insulin regimen, basal bolus. By giving a dose of subcutaneous insulin, and then discontinue intravenous insulin 1 to 2 hours after the subcutaneous dose has been administered to ensure a seamless overlap and prevent a gap in insulin coverage. For example, stopping 4 insulin too soon without adequate subcutaneous insulin can lead to rebound hyperglycemia and ketoacidosis. Always remember to overlap 4 and subcutaneous insulin for 1 to 2 hours during the transition from DKA management. Question 25. A patient with Addison's disease reports increased fatigue, nausea, and dizziness. On assessment, the nurse finds a blood pressure of 90/60 millimeter of mercury, heart rate 105 bpm. The patient states they recently ran out of their prescribed hydrocortisone and have not taken it for 2 days. What is the priority nursing intervention? A. Administer oral electrolytes. B. Administer intravenous 0.9% sodium chloride rapidly. C. Obtain an ECG to assess for hyperkalemia. D. Prepare to administer intravenous insulin. Answer B. Administer intravenous 0.9% sodium chloride rapidly. This question tests your immediate response to a developing adrenal crisis in a patient with known adrenal insufficiency who has missed their medication. The concept is the initial management of hypovolemic shock. The keyword clues are Addison's disease, ran out of their prescribed hydrocortisone, increased fatigue, nausea, dizziness, and vital signs BP 90/60 millimeter of mercury, HR 105 bpm, all pointing to an impending or actual adrenal crisis and hypovolemia. The priority nursing intervention is to administer intravenous 0.9% sodium chloride rapidly to correct the profound dehydration and hypovolemia that result from the lack of aldosterone and cortisol. For instance, this fluid resuscitation is crucial to stabilizing the patient before other treatments can take full effect. Always remember that in an adrenal crisis, fluid replacement is the immediate life-saving priority to support blood pressure.